North Lake County Hospital District meeting, and I'd like to call this meeting to order. And I'd like to have Mr. Ken Bragg lead us in prayer, please. Please stand.
Let us pray. Dear gracious Heavenly Father, we thank you for the opportunity to come together to work for the betterment of our community. We ask you to bless the actions taken here tonight. May they be in your name to provide service for those in need. We ask you to bless each person here and their families as we go about our work to work. Thank you for the opportunity to live in our wonderful county and our great state in the United States of America. In your name we pray. Amen.
Do I have a veteran here that would like to lead us in pledge? A veteran in the room? Any veterans? Mr. Bragg, go ahead.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Mr. Bragg. We'll take roll call. Oh, I'm sorry. We're going to do swearing in of Mr. Mark Jordan.
Yes. Mr. Jordan, would you raise your right hand, please? Do you solemnly swear or affirm that you will support, protect, and defend the Constitution and government of the United States and of the state of Florida? That you are duly qualified to hold office under the Constitution of the state, and that you will well and faithfully perform the duties as trustee of the North Lake County Hospital District on which you are now about to enter?
Yes, I do.
Now you want roll call.
Welcome.
Thank you all. I want to, if I may, thank you all for the gracious invitation, and I hope that you will continue to be gracious with me as I learn the.
Roll call.
What, you're going to do roll call?
Yes. Mr. Harper?
Here.
Ms. Hooper?
Here.
Mr. Hurley?
Here.
Mr. Jordan?
Here.
Ms. Price?
Here.
Mr. Smith?
Here.
Our next agenda item is presentation and approval of the minutes of the meeting held on January 18th of 2024. Are there any corrections or additions? Do I have a motion to accept the minutes as presented?
So move.
Second?
I second.
All in favor?
Aye.
Minutes pass. Financial report, Purvis Gray.
I'll introduce. As a matter of reminding the trustees, the Florida statutes require that the organization have a financial statement audit every year. There are financial statements that we do with the accounting and reporting for, and you all engaged Purvis Gray and Company to present their audit and audit opinion and findings on those financial statements and internal controls every year. With us today is Mr. Tim Westgate as he approaches the podium to present the audit opinion and the findings from the audit, if any, as well as take any questions you might have about his audit opinion. If you have questions about the financial statements, though, those should be directed towards us. So without further ado, we'll introduce Tim Westgate from Purvis Gray & Company.
Thank you. If you could just state your name again for the record.
Thank you, Matt. My name is Tim Westgate, audit partner with Purvis Gray & Company. Allison Stone is the audit director on it, but she is doing a middle school orientation this evening for next year for her daughter, so wasn't able to join. This evening wanted to review the results of the audit with you. It is for the year ended September 30th of 2023. You should have copies in your packet there. Really just touching on a few highlights of the results of the audit, put a little bit of geography and context of what is the audit. Matt already mentioned it is required under Florida statutes, and with those requirements you're also submitting those reports to the Florida Auditor General, which if there were issues could get passed up to the Joint Legislative Audit Committee and lots of steps beyond that. So just touching on a few things, if you did want to flip pages, absolutely no reason to, but if you wanted to follow along, page 1 is your primary piece. That is your independent auditor's report. That is the number one piece that is required under the statutes. That's the number one piece that external parties should have most interest in, Auditor General does, and it's particularly that second paragraph that's on there. And that does state that in our opinion, in all material respects, the financial statements do present fairly. That is an unmodified opinion, a clean opinion, highest level of assurance that you can have for an audit. So I commend you and your efforts in attaining that in relation to your financial statements. As Matt already touched on, the letter goes on to talk a little bit more about what the audit is. Has some reminders in there that management is responsible for the financial statements. The board management is responsible for internal control over financial reporting. And our responsibility is to issue that opinion based on our audit, which it talks about the sampling methodologies and similar approaches in the audit. Letter also talks about the audit being conducted in accordance with government auditing standards. So that is a next level up, a higher level of standards for the audit beyond those just required by the AICPA. And with that, there's more reports that get issued. So if you were flipping pages, there's a letter in the back or a report in the back on page 16. For context of that one, that is the independent auditor's report on internal control for financial reporting and on compliance and other matters based on the audit. So as part of our audit, we look at internal control for the purpose of designing our audit, but don't issue an opinion on internal control. However, if during that process we encountered material weaknesses, significant deficiencies, or as well if we encountered non-compliance matters with laws and regulations and statutes or grant agreements coming or going, anything that would have a material impact on the financial statement, this is the location you would find those. Pleased to say, and a little bit of a joke there, this is a report that the newspapers typically would not be interested in because there's no findings in there. It is very standard language. We appreciate being able to issue that report and not have contentious issues there. Following report that's in there starts on page 18. And that is the management letter that is issued in compliance with the rules of the Florida Auditor General. The audit is conducted as well in accordance with Chapter 10.550, Rules of the Auditor General. And in that letter, if there were prior audit findings to discuss, if there were matters such as deteriorating financial condition, inability to meet payments that are coming due, if there were matters that we felt we needed to disclose to you in writings, sort of that in-between findings. So they weren't the material weaknesses, significant deficiencies, but things that we needed to put in writing and make you aware of, those would be in there. Pleased as well that it is standard language in those reports and no such findings in that regard. So we appreciate that. The last piece that I wanted to touch on, there's a two-page letter that is addressed to the Board of Trustees on Purvis Gray letterhead. That one is a required communication that is from the auditor to those charged with governance, in this case to the board. This is not required under the external reporting, but it would talk about if there were changes in the accounting policies, practices from year over year. If we had encountered difficulties during the audit, it would talk about it in that letter. We're pleased to say there were no such difficulties. Corrected, uncorrected misstatements, it is a topic in there. Everything that we discussed during the audit process was adapted, and we feel that everything's in compliance. So that letter is a required thing, but again, standard language. It is a great opportunity to thank you again for the structure that you've set up. We do get great cooperation, timely cooperation throughout the audit process, and we thank you for that as well. So with that, I'll open to any questions you have related to the audit.
Do we have any questions for Mr. Westgate?
Sounds good.
We have to vote on that? No.
Yes, we do have to accept the independent audit's report after moved.
I need a motion to accept the auditor's report.
So moved.
Second, all in favor?
I do.
Thank you, Mr. Westgate.
Thank you very much. Thank you.
New business, presentation of quarterly audits. Oh, I don't have his name. Oh, there he is. Mr. Halleck? Good evening. If you could just state your name for the record again.
Good evening. Yeah, Farland Halleckman. I'm the CPA from MSL, responsible for the audits to provide accountability to the providers that their submissions of indigent claims are eligible and appropriate for reimbursement. And the report is about that. I'm sorry I was running late. The traffic was worse than I expected, and hopefully all I missed was the Pledge of Allegiance. Okay, all right, thank you.
Just in time.
All right. All right. The report is basically the standard wording that we always issue. There's one thing in there that particularly that I did want to bring to your attention, and it has to do with the way that the budget limits the funds available for the providers at some point. We have one provider that has already now in the second quarter exceeded their budget, and that's Advent Health Waterman. Last quarter, they submitted, and when I say last quarter, that's your first quarter of your fiscal year that ended in September. They had submitted and already been reimbursed $722,000. Pardon me. They had submitted and already been reimbursed. I was reading from the wrong line. $533,000 from their $806,000 budget, and so there's only $272 left to get for the whole rest of the year. And in this quarter, end of December, Waterman Hospital, combined inpatient and outpatient, submitted $1,591,000. And so they're already $785,000 over their budget, so that they're not eligible to get paid unless you all adjust your budget. So they're kind of done for the year. I don't know what that means as far as your mission and what you want to do with the resources available, but I just wanted to make sure everybody understood that, and so that if you think action is needed to adjust the budget or what you're even able to do, that's really a question for Meredith, is what you're allowed to do to rearrange funds from any providers that may come in under budget and their funds be unspent. Maybe they might potentially be reallocated. So I did want to bring that up to your attention. And other than that, the report is final, and we concluded our procedures just fine. Are there any questions?
Not this time.
Any questions? I see none. Need a motion? Yes. Need a motion to accept?
I move to accept the report from.
A second.
All in favor?
Aye.
Aye.
All right, thank you very much.
Thank you so much.
You're next on the agenda, talking about the Chapter 2014-015.
Oh. All right. Yeah, the next thing on the agenda is that the state of Florida has changed the definition of medical indigency. So when Mr. Metz originally designed HB 1299, the definition of indigency was 200% of the federal poverty guideline. And it's been that ever since, but effective, was it April, some date in April, pretty recently, the state decided, March 21st, okay, good, thank you. The state decided to change that because inflation's been going wild, and they're finding that indigents, particularly the elderly indigent, are having to make choices between buying food and buying medicine, and the inflation for basic living, rents and food is eating them alive because they're on fixed incomes, and so if somebody's getting the minimum kind of Social Security check, yeah, they're getting a COLA, but it's not enough to cover the difference between real inflation and what the government tells you inflation is. And so the hardship is there, and Governor DeSantis saw that and adjusted to 300% of federal poverty guideline. Now, at that point, Meredith wrote to me and she sent me the rule and said, well, how is this going to impact your procedures? So I did go back to 1299 and reread it, and I suggest each of you take a look at it again. And that, I think what it's telling us is we use, it doesn't say use 200%. It says use the state's definition of poverty, of indigent. And so I think we need to adjust our eligibility to 300%. And what that's going to do, obviously, is it's going to make a lot more people eligible for the hospitals and the clinics to submit as indigent claims. So you're going to get more indigent claims just because of that rule change. And again, that's, I don't know how that impacts your mission or your considerations of the budget and how much you want to tinker with the millage as a result, or whether you want to do that at all. Maybe you just want to say, okay, more people are going to put in claims, but this is the maximum amount we're willing to pay, and the providers are out of luck, or we're going to try to make some adjustments. Those decisions are yours, because you're charged with doing the right thing by the people and the people's money. Did I answer the question?
Yes, were you going to talk about a possible webinar? Were you going to talk about a possible webinar with everyone?
Oh, boy, thank you, yes. We did a webinar this summer with all the providers, and it's recorded and it's on, they can watch it again if they have turnover. 'Cause that's what we were finding, boy, over and over again, we were finding the same errors happening, and we take those errors and we extrapolate them to the total amounts submitted. So we reduce the total amount submitted by the errors that we find in our sample. Everybody follow that concept of extrapolating the error rate to the total population of submissions, and it's costly to the providers to make errors. And we're supposed to do that. That's in the agreement of how we're supposed to do it. So we do follow those rules, and if it results in them not getting reimbursed something, then I mean that's what it is. My suggestion is don't make those errors. But they've had a lot of turnover since COVID, and a lot of baby boomers are retiring, and they have a lot of institutional knowledge on how to do things, and the new folks are making mistakes because they don't have that experience, and until they get that experience, they won't have it. And so we said, it's been a few years since we've done this, but let's have a training. And all the people that are involved in preparing the submissions packages were on this webinar, and we used Tim Powell, who was the consultant that assisted us with the original training when this was first set up. We had some pretty intense times with going, back then we didn't use webinars. Those weren't even, you know, they didn't even dream about such a thing. We took it on a road show, went to physically to each provider and trained them. And Tim helped us put together this webinar. We taught, again, how to avoid submitting ineligible claims, how to read the district map to make sure that if somebody is really living in the district, because that was a common error that we would get is people in a zip code that we look at and we say, that zip code isn't in the district. And so that costs them money because that error gets extrapolated. So we refreshed them on those rules. However, this 300% thing is going to add another, we're going to have to refresh what we just refreshed. So we'll do that again sometime over the summer. I don't know exactly when, but probably hopefully before the next submission. Just letting you know that that's going on in the background. We're making sure that the providers know what they're doing. It makes our jobs easier, and it, again, helps with the accountability for the whole process. Okay. What else did I forget, Meredith?
Very well.
Yeah,
Okay,
that's
all right. Thank you so much.
Thank you so
Yes, sir.
much.
You probably don't have this information, and maybe one of the hospital board executives can give me an answer. But is there any, you don't probably have a demographic study per your district, how this percentage changes that demographic group? You know, every district's going to have a higher volume that's going to be more affected than Key West, you know. You know, because your poverty level of people is going to be more centralized.
be more.
You know, maybe in the city of Orlando versus
Right.
Tallahassee. So I didn't know if there was anybody who has
Yeah,
that data available.
that data would be available through, there's Claritas, which is the agency.
what's that about?
Claritas is owned by Nielsen.
Is it Claire?
Claritas. And we subscribe to Claritas because we have, MSL actually owns the MSL Gervin Group in Tallahassee, which is, if you ask me, it's the preeminent health planning firm in the state. And they assemble data for hospitals and nursing homes and healthcare providers so that they can make intelligent decisions on expansions and new service lines. And so they can take the Claritas data. Claritas, they take the age and income and acuity information from the U.S. Census and put it into a massive database and massage it, and however they do with their magic. And that, if you subscribe to it, you can run a query and say, well, how many people are going to die next year in Lake County? What are they going to die of? Okay, of the people that are going to die of cancer, how many are going to die from cancers that kill you fast versus cancers that kill you slow? So if you're going to if you're at the hospice and you want to build a new hospice house, you'll be able to project over the next 5 years whether that hospice house is going to fill up and whether there's a need for building it or not. So those kinds of decisions. Also, if you're going to apply for a certificate of need to build a nursing home, you can see how many age and income qualified people live in that general area. Let's say your market area is a 10-mile radius. So you plug those zip codes into Claritas, and it tells you age and income, and then how many people are going to have certain morbidities. Right. And it'll tell you. So I think that the information of the income is going to be able to tell us how much expansion in indigent care is going to be provided, as defined by the state indigent care.
Right. Is there something that can help guide? I'm sure all these administrative opportunities we're working with now probably have that data. I don't know if they're accessing it or not, but is that something, data that we could review in a simple format of some kind for this service area that we're servicing?
Yeah, I think it could be put together. Yeah.
You don't need to be here and present, but could you provide that maybe to our next meeting so we could have something that can be submitted to Christie's?
Okay. All right.
Does that make, you don't have to be attending.
You remind me to do it, because you remind me to do everything. You're great. Thank you.
All right.
All right. All right. Thank you.
And if I can get maybe how old history versus new history, like 200 versus 300.
Yeah.
Does that make sense?
Yeah. Yeah. It's, it can be done.
Okay.
Yeah.
I don't want to overburden you, but
Yeah,
it would be
no,
good information to have.
I understand.
Mr. Halleckman?
All right.
I've-
Happy to help.
I would want to ask a question before you got a chance to leave there. And obviously, increasing that threshold by, 50% more, there's going to be more people that qualify, what you're identifying there. But the statutes that follow, that we have for 258, that it outlines what the indigent definition is, with the new law that's come in, with DeSantis just signed in, does that require any change to 258, in your opinion, or is it automatically recognize that within our parameters of
I'm
identifying?
sorry. I'm hard of hearing. Could you speak
Is your
more
speaker-
into your
is your
microphone,
speaker on?
please? Thank you.
Is it green light on?
There's a little green light on. How's that, better?
Much better.
All right.
Thanks.
Sorry about that. Hate to be up on this thing, but what I was asking primarily was in statute, the chapter 258 that we filed, that's established this board, there's an identification of indigent care, which gives definition, and it talks about the Florida Health Care Responsibility Act and so forth.
Yes,
Right, that
FCRA,
gives a 200
yeah.
definition. This has been changed recently to
Yes.
300 without any changes to this 258. That's the new threshold, correct? In
That's
all
correct.
aspects of legislation that you know of.
As far as I understand it, it's pretty plain and simple.
It seemed reasonable, but I just wanted to see if you had any.
Yeah.
And also, because that increase of that large of a difference, from 200 to 300%, could you speak anything on, not everybody who, just because there's that many poor people, they're all eligible for these funds, that still doesn't change, they may be eligible for other types of payment, Medicare and other Medicaid that would disqualify them anyways. So not all of that, those new people captured in that addition, that new cap are going to all fall in that necessarily. So how much is this? Seems like a pretty big increase, and we've
Yeah.
had great inflation, like you said, but how much of that, it's not necessarily going to encompass that many more people perhaps because of other requirements within the statute that disqualify people because of other types of insurance or Medicaid or so forth.
So that's very, very good observation. And my response is, well, yes, but also no, because it depends, and here's where the Claritas data is important, is because those that, like let's say Lifestream, they deal with substance abuse, mental health, people that live in the woods behind the 7-Eleven that don't have ID and they're completely off they're not Medicaid. The migrant farm worker that breaks their arm at a firm business is going to show up at the hospital. They don't have Medicaid. They're not going to get Medicaid. Those guys are going to always be there. If there's somebody that was making 250% of federal poverty and now might be eligible for Medicaid that previously wasn't, that's great. The hospital's social workers need to get busy with those people to get them to apply for Medicaid. However, a lot of people just don't or won't. And, we find in the nursing home business a lot of times that the families don't cooperate in pulling together documents and doing all the paperwork to bring bank statements and everything to get those applications from Medicaid completed, and the patient ends up expiring, and the nursing home never gets paid. That kind of thing happens all the time. So the answer is yes, there will be some,
Back to his
but yeah,
statement to him answers that very well.
yeah.
But yes, as a paramedic for decades, I know exactly what you're talking about. We, not a driver's license, much less an insurance card, so I know exactly what you mean, so.
Much less an insurance card, right, right. If they had an insurance card, they wouldn't be getting, being submitted for reimbursement from us. We're the payer of last resort, last resort, after everybody else that maybe could have paid for it. Yeah. So it's a very complicated question. I don't know really how to answer it. If I come up with some ideas, I'll report to Meredith and she can talk to you.
Thank you so much. Thank you.
All right, thanks.
Mr. Halleckman, appreciate it.
We're on the discussion of the budget scenario worksheet. Mr. White,
I'll handle that as well.
We need to make a motion on this.
I don't think we do, not on that.
Okay.
And I guess I'll be the third straight CPA to start talking, which is probably riveting for the group, I'm sure. My intent is, before you have your discussions, is to go over the truth and millage guidelines as it pertains to dates and decisions and just general timelines. Included in the packet under 6C was a document from TRIM. That document does a really great job in just a few pages of laying out the timelines. I'll go through that briefly, and then we'll talk a little bit about how that applies to this organization. The intent, one of the items this trustee board is tasked with is setting a millage to raise funds for indigent care. That's at the discretion of the trustees. That's one of the decisions you all make. And in order to do so, these timelines have to be followed. So it starts day one, which is on page 3 if you're at the back there. July 1st, the property appraiser certifies a taxable value, essentially establishing what the base tax value is that your millage can be applied against. After that, by August 4th or a little before, we have to certify to them what that tentative millage may be from this board. Beyond that, there are other dates listed, but ultimately on or before October 3rd, a final millage has to be established, and the process from there is outside of the trustees' purview, meaning the monies are levied and provided to this organization. Yes, sir. Do you have a question?
That last date you said
On or before October 3rd. And if you look at page 6 of the attachment, it states that in there. So how do those dates apply to this board? The underlying taxable value and how that might apply to what a budget scenario might be. We're early on that. We're early on the discussions because there's 3 pieces of information that have to be included for us to be able to present to you a budget scenario, and we don't have any of those 3 yet. One being the underlying asset value certified by the property appraiser July 1st. A second one being maybe second and third combined as to what are the needs of this community and what are the desires of this trustee and intending to fund those. So without those pieces of information, we're unable to provide a budget scenario for you. How does the timeline of our meetings today and forward comply with these TRIM is that we're having a meeting here in May to get a brief understanding of what the providers are going to be looking for, and obviously the trustees will discuss what their considerations are for that. And a tentative millage can be set, and that tentative millage will have to be advertised by that August 4th date. So the maximum mill or millage is 1 mill for this trustee board. If 1 mill or less is agreed upon by the trustees at today's meeting, that will be advertised on that August 4th, by that August 4th date. If not, if there's a stalemate or decides not to go to a vote on that, the only people with the authority to set a millage is the trustees, and by not setting one in advance means that it will default to being listed or advertised at 1 1.00 mil. And the reason for that is because that saves the decision-making ability for the trustees, 1 mil being the greatest you can be at. And if you start coming down upon tentative millage setting, it becomes very costly to go up again later. So if you all do not make a decision on that, one cannot be found. An advertised mill of 1.00 will be established so that it protects your rights to make those decisions as the time frame lays out. So that's a general synopsis of where we're at going into tonight's meeting. Obviously, there's a meeting in August with a much more detailed funding request. There'll be a mid-September meeting where the millage will then be further discussed. And then by the end of September, there'll be a last meeting, and the millage will then be accepted as final. And in those September meetings, we will be able to provide budget information. We will have the taxable value. We will have what the tentative millage that is the maximum because you were unable to set one lower, or you've set one lower, we'll know what that is. We can start that process of providing financial information. The funding request will have come in as well. So tonight, we'll discuss that, I'm sure, and then moving forward into the August and September meetings, they will be honed in even more. Are there any questions about that, the trim process, and then how that applies to our meetings? Excellent. Oh, I'm sorry.
Yes, I do.
Yes, sir.
This is a special meeting, this May meeting, so would normally, I would guess, in a half educational question here, normally would meet in August. The established statutes in 200 that tell about the trim process, they've been there and they're going to stay the same. So why this, what does this meeting do versus if we just met in August?
So at the will of the trustees, there was some concern that advertising a mill that was not approved or discussed by the trustees by that July 1st date didn't sit well. So we scheduled this meeting both last year and this year for the trustees to discuss that and come to a conclusion amongst yourselves so that you still felt in control of that.
I saw that in some of the minutes I read from past meetings. So there was a question about if in one of these meetings, which I would like to first ask with like a definition and clarification between tentative millage and proposed millage.
Yeah, the proposed millage is what we're going to have if there's one tonight. Tentative becomes a little bit more under the regulations of trim. The trim regulations don't discuss, in the timeline provided here, don't discuss proposed because the proposed is not as, it does not fit in the timeline of the tentative, if that makes any sense.
Yeah, I saw both of the words in legislation, so I was just wondering with our discussion, does this discussion today, if we've come up to an agreement, is it one of these identified, or has it become it's not a proposed trim?
So based on the timing of the meetings, a proposed would then also become the tentative if there's no other further meetings prior to the certification date on August 4th.
All right. Thank you.
Okay. Anybody else have any questions? Am I on? No other questions?
I may have one more for him. So there was also a question, some past minutes that I read, there was a discussion, I believe it was Mr. Hurley that questioned the setting a particular rate as a board, that it prevented any movement upward. It would set a ceiling per se.
That's not true. The statutes in the trim allows for it to move back up.
You said,
however, once it's officially advertised according to these dates, the cost to then re-advertise falls on
that official advertisement date, where does that come? That could not come from this meeting, correct? Or could it?
Clarify the question, please. I'm sorry, I'm not following.
You just said that it would come after an advertised. It would be difficult to move it back up, correct? After it was advertised.
Correct, yeah. Once it's been advertised, that August 4th date, it can be moved up thereafter at the expense of the trustees.
Right, so what sets that would be what we decide tonight.
Based on the schedule of our meeting dates, that's correct.
So if whatever it is indeed more difficult to move that up above what we might decide tonight.
Sure.
Okay,
That's a good way to say that, yes.
That's all.
Not to say that another meeting couldn't be scheduled prior to that August 4th date, but there's not currently one.
It helps me understand the context of the meeting since I was not involved in the past from what I read. Thank you.
My pleasure. Any other questions?
Any other questions? No?
Thank you, Madam Chair.
Guess we'll start with presentations. We're going to go ahead and start with presentations. Advent Health, you get 5 minutes.
Good evening.
Welcome.
Thank you for having us here. My name is Abel Berry. I serve as President and CEO of Advent Health Waterman. Appreciate the opportunity to speak with you again. Some of this will feel a little repetitive, but I hope you'll indulge me. Historically, the work of providing care for the uninsured in our district was a collaborative and non-adversarial relationship between the taxing district, the hospitals, clinics, and the community at large. This was the case because we are fundamentally rooted in this belief that the singular job of the taxing district was to provide care for those who are unable to do so for themselves. Over the last few years, it has become very evident that we no longer share the intended purpose, and to state the obvious, we no longer seem to share the same priorities. I don't think anyone would challenge this statement that, objectively speaking, the hospitals and clinic and 60% of North Lake residents still believe we should collaborate to provide care and funding for the uninsured among us as dictated by the Florida legislature. Whereas 50% of the board members here strictly believe that delivering tax cuts is their primary responsibility. These are legitimate issues, don't get me wrong, and I maintain there is nothing wrong with each group pursuing this objective. The problem becomes the platform used to obtain this objective. Again, the mandate reads specifically, the North Lake County Hospital District is an independent special district that was created by the Florida legislature to provide a means to pay for indigent care delivered by local hospitals and clinics. Nowhere does it say to defund the district to achieve tax cuts. It most certainly does not provide a means to substitute one's feelings for the vote of most residents done in a referendum. For all intent and purposes, you as a board are an insurance company. As I stated at my last public presentation, you collect premiums by way of levying a tax. You provide coverage for lives, in this case the uninsured in the district, and you answer to shareholders, in this case the voters of the district, and like every insurance company that processes claims, you have auditors selected by you to do due diligence on the appropriate dispensation of these premiums. That is your fiduciary obligation. Somewhere along the way, though, this board has kind of abdicated that responsibility to care for the uninsured and move that burden solely on the hospitals. I would respectfully direct you back to your legislative mandate. It is to provide for the care of qualified uninsured residents within the district. Again, to those who continue to believe the free clinics we operate address all the needs, I will pose these set of questions that I hope you dialogue before you vote. Do these clinics perform surgeries, endoscopy, cath? Do these clinics provide CT, MRI, nuclear medicine? Do these clinics provide cancer care, radiation, chemotherapy? How about rehab services? Are these clinics open 24/7 to respond to a stroke or a heart attack? I challenge you to answer these questions before you vote to defund this program again. Lastly, the relationship between us hopefully gets a reset. I relate to you as I do every insurance company, fairly, honestly, and equitably, but also with mutual expectation of respect and accountability. We deliver a service. Every insurance company, including Medicare and Medicaid, pay when the bill is due. The district is the only payer that dines and attempts to dash. When we come before you, it is not for a handout. It is for reimbursement for services those lives you are responsible for covering have received at our facilities. Your patients, covered by the statute you operate under. The last few years, this board has acted more like a benevolent benefactor awarding, restricting monies as if this is an art gallery. We are not an art gallery. We are the means by which you get to fulfill the very mission of why this board exists. It is my hope that you take a broader perspective on the responsibilities bestowed upon you. Thank you for your time.
Thank you. UF Health?
Hi, good evening. Phil Braun, Vice President, General Counsel with UF Health. I will try not to repeat what our colleagues at Waterman believe, because we feel the same way about this district and its importance to the people. But there are three things I did kind of want to make a point, particularly about why you're here today about setting a tentative millage. I do think it's too early to set a tentative millage. Unfortunately, your meeting dates, I understand, don't give you another chance in August, but you don't even have the property appraiser's report. You don't even know what property values are. So you certainly can't set a budget, and if you can't set a budget, I don't know how you can set a millage. And despite the belief that in the past that nobody wanted to set a millage or didn't set a millage, or the board didn't do its job, that's not true. What the board at that time understood was they needed the flexibility, because of the timing of the dates, to set the true millage, the actual millage that people get taxed, in the September budget hearings. That's what the budget hearings are for. And if you cap yourself now, you will lose that flexibility. So I really want you to think about doing such a thing and setting such a low millage before you have property values, before you have funding requests, before you have a budget. I don't think it should be done. Hopefully you'll wait and leave it so that you can have all the information. I understand you may not give a mill. That's understandable. Property values may be up. We may not need a mill. The other thing I would like to point out is that when you see the submissions, and I appreciate what Varlin was saying about Waterman already reaching those submissions, I think it's always been the case that at the end of the year, there's a true up, and if there are unused funds, there are unused funds. Unfortunately, I will tell you there probably will not be unused funds, at least not by the hospitals. And our submissions won't reflect what our actual need is, because there are intensive resources that are needed to qualify these folks. I know it sounds like they just meet the poverty guidelines. You actually have to put resources in to qualify them, submit to the auditors, and do those things. And we have taken the position recently that if we're not getting the funding, we don't want to burden our already burdened system by just qualifying people just to qualify them, right? There's no resource, there's no funding of them. I will submit to you that if you gave both hospitals $4 million, both hospitals would qualify residents for that's how much the need is. It's not that we would go out and find them. There actually is a need. The other point I want to make, and similar to Waterman, is that this is not, it's not for services that aren't provided. We provide the services. It's not a handout. We don't make a margin on these services. This is to pay the cost of these services. And I can tell you, nobody decides and wakes up one day and says, I want to come to the hospital, right? So these people that come to us, and to add the burden of then having a hospital bill, because I know it sounds as if we just give free care out. We still bill people for that care. Now, whether they're able to pay us or not, they may not, but they still have that burden. I don't know if any of you, when you get a bill, don't want to pay your bill, right? I mean, even the poorest person in the world wants to pay their bill. There's a sense of obligation. They don't want to just have it hanging over them. What this funding has done, and the reason the statute was put in place, is for that very reason. People don't always choose to get health care. It's not a choice to get health care. Sometimes you just have to have it, and you may not have the needs to pay for it. And if you don't, this district helps with that. And so I hope you consider that in your mission. Happy to answer other questions, but those were the three things I really kind of wanted to point out, and I hope that you'll give us another opportunity to present the needs of the community, maybe find some more of that data. And if you all have questions, I think this one thing good about this meeting is if there are things you want to hear from us, if there's things you want to know to help you make that decision on that final millage, please let us know. We're always willing to try to help and provide you additional information. Thank you.
I want to thank you personally for the visit we had, and I learned quite a bit from you, so that was and Mr. Berry, thank you as well for that. Appreciate it.
You're welcome. And anybody, we've tried to meet with everybody as they've come on, but if again you need to meet with us again, more than happy to sit down with any of you at any time. Just give me a call.
Thank you, Mr. Braun. Livestream Behavioral Center.
Jacob Temple for Livestream, Vice President, Acute Care Services. So as far as the hospital is concerned, we are expecting to ask for the same as last year as far as amounts go. We, unfortunately, I kind of have to report the same findings, which is, every 11 minutes someone, dies by suicide, according to the CDC. So it's just kind of a shame that we continue to have that as in our public, health crisis. So certainly, Livestream's efforts are to keep, all those residents safe. And we actually are happy to partner with Advent Health Waterman and UF. We receive calls every day to help take those patients out of their emergency room and place them into our hospital. So once they're medically cleared, we do our best to take them out of the emergency room so that other patients, residents, can actually receive medical care and then place those patients in our facility where we can handle the Baker Act, Marchman Act, and so forth, and their substance use. So otherwise, I don't really have any additional information at this time, but those are our plans.
I didn't catch your name again.
Jacob Temple,
Jacob. Okay, thank you, Jacob.
and I'll come back before the other primary care clinic. Any questions?
I think so.
Okay, thank you.
Advent Waterman Community Clinic.
Good evening. How's everyone today? Good. So my name is Edlin Fernandez. I'm the manager for Advent Health Waterman's Community Clinic. We're located in Eustis, right across from Lake Tech. First off, thank you for providing me the opportunity to give a sneak peek of what we've been experiencing thus far. As of April, we've already received an over 50% increase in referrals compared to last year, showing the need in our North Lake County market. We've seen a 41% increase in new patient volume this year compared to last year, and that's at 200% of the federal poverty level, which we're now going up to 300. We've already surpassed our proposed number of patients we expected to see in a year, and we still have a few months left. So we've currently seen 1,366 patients. We had proposed 1,100. Last cycle, we also surpassed our estimated patient volume projection, and our clinic did not receive complete funding as the money had been rolled over. I value this committee's commitment to our community clinics, and please ask that you consider our increased volume to please cover the patients seen this cycle. We have a backlog of patients pending Medicaid denial letters, which allows us to establish a patient. We expect our volume to further increase once those denials come in. It's because of Medicaid unwinding. That time has lapsed and changed, and so we do see an increase. The state of Florida recently increased the federal poverty level to 300%. We expect to see more patients as a result. Our clinic is here and meant to care for those in their time of need, getting them back to feeling whole, where they can get back on their feet, back to work, and back to being productive members within our community. Many of our patients work in places we all go to on a regular basis. Lastly, I would like to share my appreciation of the committee's continued past comments of support for clinics such as mine as we continue to serve as an efficient primary medical home to the uninsured and indigent members of our community. We help to reduce the patient's needs to use the ER for medical care we can provide, which opens those spots for the truly emergent visits that we would all need. Because again, nobody wants to go to an ER, right? We also work to connect patients to resources in the community to address food, housing insecurity, referrals to specialists, and we do that collaboratively. And we work diligently with our community partners, such as Livestream, which we also refer to. As a clinic, though, our patients need labs, imaging, surgeries, cancer treatment, and the list goes on. Those services are provided by our local hospitals. Thank you again for your time, and I really do welcome any of you to our clinic to tour it.
Thank you. I'd like to get some information from you before you leave so I can.
Yes, of course.
Thank you.
Thank you so much. Community health centers?
My name is Mark Dickinson. I'm VP and Chief Financial Officer for Community Health Centers. The one thing I would just say about our operations through the first 2 quarters of this year, our indigent patients are up about 20%. And as the last speaker said, it has a lot to do with the Medicaid unwinding. People that were on Medicaid during the pandemic are now off and they're uninsured, so our volumes have gone up. I cannot see a scenario where at our centers we are going to go to 300% of the poverty guidelines. We're probably going to stay at 200% because of our federally qualified health center status. The federal government requires us only to go up to 200, so I don't see us putting in special dispensation to try to, we have enough visits at 200%. So when the budget time comes, I may ask for a small increase over what we're currently being funded. But I do not, like I said, I don't anticipate going up to 300%. So there will be no, we're not going to have additional, we use up all the funding we get as it is. So that's, and everybody else has been very eloquent about, stating needs. And I just say one of the things that we're proud of at Community Health Centers is we really, really try to work with all of our hospital partners in Lake County and Orange County. We're in both counties to try to keep people out of the emergency room. We can provide, the primary care needs much cheaper than an emergency room visit. So that's our main goal, is to be the best that we can be at keeping people out of more costly circumstances. So thank you.
Thank you, Mr. Dickinson. Community Medical Care Center.
Good evening. My name is Tamara Youngren, and I am the Ministry Director at Community Medical Care Center in Leesburg. It is both an honor and a privilege to be here tonight to share about our ministry. Thank you to the board members for your continued support over the years. Our facility opened in October of 2000, making this our 24th year. We have always enjoyed a strong partnership with UF Health Leesburg and believe this is cornerstone to our success. Tonight, I would like to review current activities as reported on our April stat report. Total patient encounters, 206. Encounters eligible for reimbursement, 150. That leaves 56 encounters that do not qualify for reimbursement from the tax district. Those include dental visits and pending eligibilities, among other reasons. Our current patient visits have increased by 26% since the beginning of the year. And we saw 23 new patients in April. We have reviewed a few numbers, and now I would like to share how we are able to provide our services. Community Medical Care Center relies heavily on volunteers in all areas of our clinic. They give freely of their time, talents, and expertise. We currently have contracts with 34 active medical and dental professionals and 22 active support volunteers. Our staff and volunteer physicians rely on our relationships with the community. Our patients need diagnostics, procedures, surgeries, cancer treatments that are not able to be provided in our scope at our clinics. When this happens, UF Health provides their facilities and their staff to provide our patients that are approved for charity care at the hospital with services. Several of our specialists that work with us provide services for our patients in their offices. These include GI, pulmonary, and podiatry. Again, we don't have the needed equipment in the clinic to care for the patients. Other specialists choose to see the patients in the clinic, and these include internal medicine, cardiology, hematology, oncology, gynecology, pediatrics, ophthalmology, dermatology, and a diabetes educator. Over the years, we have built a great network of community partners who support the clinic in funding, in addition to the tax district. These include, but are not limited to, UF Health Foundation in collaboration with community clubs to provide mammograms and cancer screening diagnostics, Parity Financial to provide mammograms, Harbor Hills Ladies for pap smears and labs, Florida Baptist Convention and Waterman Communities Unrestricted, First Presbyterian Church of Wildwood for glasses. The Rogers Foundation has provided funding for over 22 years for countless types of funding, computers, exam tables, an EKG machine, lab equipment. And most recently, we have a relationship with the Lions Club of Lady Lake, who just this month provided a check to buy new eye equipment, which we used for the first time on Tuesday night. And not to mention the many private individuals that send help. In addition, Community Medical Care Center is located on the campus of the Christian Care Center. We work in conjunction with our sister ministries to provide additional services: Fresh Start, Job Placement, Benevolence Center, Food and Clothing, Pregnancy Care Center, People Helpers, Counseling Services. The stats we reviewed represent individuals. They're not just numbers. It represents a young man who is a truck driver who lost his job due to uncontrolled diabetes. After working with our doctors and diabetes educator, was able to get his job back and provide for his family. A wife and mother who is a caregiver for a disabled husband and a child. An undocumented family in need of school physicals to get their children in school. We provided the physicals and also a translator to accompany them to the school to assure success. The clinic offers a hand up, not a handout, to our patients, and they are what is behind these numbers and these stats. Thank you for your support and making it possible to have this incredible network to be in place to make our communities healthier and stronger, one patient at a time.
Thank you so much. Livestream Primary Care Clinic.
Jacob Temple. Just appreciate the opportunity again, to present on behalf of Livestream. So we also offer our primary care clinic so that we have the whole continuum of care between primary care as well as our psychiatric and substance use care. So our goal as well is to keep our patients out of the ER and handle their primary care needs for those that hypertension, diabetes, and just to help manage their overall health and as far as the psychiatric all the way to primary care. So we continue to look to ask for the same as last year. So we don't have any plans to ask for any increases. And we continue to be creative and try to figure out ways in which, to offer the same care, because we know that you're being asked a lot from several facilities. And so we partner with all of them to try to offer the patients all their needs that they need it most. So any other questions? Okay, thank you.
Thank you, Mr. Temple. St. Luke's. Is there anyone here from St. Luke's? No? Okay, so we need to start a discussion. Who would like to start a discussion on possibly doing what we're here to do today. I'll let anyone start.
Well, I would like to say hello and thank you all for inviting me in and being very gracious. And wanted to let everyone know that I would be doing my best to uphold the honor of having been appointed by the governor to this board and to the other persons on the board, and do my best to uphold an oath I took to serve on the board according to the legislation thereof. And I wanted to start out by saying, I believe from what my research on this is that we must first identify a need. And we've done that with, this is why we talked to the providers, and I've had the opportunity to meet with at least 4 of the different providers that get funds from this board and provide care out there. Having done such, the first steps towards finding out what those needs might be. Then we find out, as Mr. White pointed out, what the actual certification amount is for those actual values of the ad valorem tax. And then we can decide what millage rate to set. I think the horse needs to remain in front of the cart with whatever we do here.
Anyone else? Oops, am I on? Anyone else?
Well, I'll just say that you also have to consider that the economy right now is just devastating to a lot of people, and to raise the millage rate on their properties. I don't know if you're on. Oh, it's on. I guess
there you go.
I'm not close enough. I'm just talking about the millage rate, or on the residents that are paying for this. We're all hurting because of the economy, and you just have to take that into consideration too. So, it's difficult. And I don't know if we want to raise the millage rate or keep it where it is, or, so I guess that's the discussion we need to make.
Mr. Smith, I see your hand.
Well, first, I'd like to welcome my friend Mark Jordan to this board, and I know Governor DeSantis real well. He's a great governor, one of the best in the country, possibly the best ever in Florida. It's debatable with Rick Scott because he was great too. But nevertheless, congratulations, Mark. It's good to have a fresh voice here. We've heard the same kind of arguments that we hear every year, and it's the same good cliches and all, which I'm not saying they're irrelevant, but they are kind of getting old. The reality is we are appointed here to administer this money, and back in the history when this thing was done, it was basically a rubber stamp. It was 1 or 0. That was it. And thank God to the vision of Larry Metz. And by the way, he didn't get this done without a whole lot of angst and arguments from people from the recipient side back then, as I recall. It's been about a decade now. We did actually have a vote, and which was obviously one side had taxpayer money they had been collecting for years to put a good PR campaign and make their case, and they won by a few percentage points. And with that said, my bigger point is, in regards to this, we are allowed to do 0 to 1. We have that discretion. We can't go over 1, we can't go below 0, nor should we. But I think it's the duty of this board to look at the details. I think what Sue said is true. I think a lot of what Mark said is true as well. The reality is, I personally, philosophically, and this is not personal, I actually had once again here I'm being redundant from some of my other cliches I've said in the past, but had a CEO of a hospital of UF Shands, former one, Ed Jimenez, tell me he didn't believe hospitals should be supported by ad valorem taxes. And folks, that's what we're talking about here, right? It's a principle. And however, I do have a question though, and I failed to ask this. I should have when the people were up here giving their, stump speeches about their needs. When, especially the clinics, I know the hospitals have tons of money, but the clinics obviously rely on this a lot more. I'm more sympathetic to them, as I think most of this board is, than I am the hospitals. But in regards, are we the sole source of funding, or are we like 10 or 20 or 30%? Do they have fundraising mechanisms such as Life's Choices, who raises about almost $1 million a year without any government cheese? I'm just wondering, any of these organizations, any information? I guess we can ask that at a later meeting, but nevertheless, that's my point. So, you know, tonight, if we're going to set a number, and I agree with I believe it was real clear that you said that if we said, let's say we did 0.25, that if in August we decide we want to do 0.55, we could do that, right? We can go up or down. Last year, we were under the impression we could only go down from what we set, right?
Document provided in trim, I'm not disagreeing with you, I'm just stating what I was able to read on that, says we are able to go up if we pay to re-advertise the adjusted rates.
And I did call and talk to Mr. Baker, and he said that we can't. Once we set something, we can go down, but we can never go back up. And I just wanted to relay.
But my understanding was that was after July 1st. Once that's done, we can't go down, right?
We can't go up.
We can't go up. I'm sorry, you're right. But
Correct.
at this point, if we would like to say tonight, let's do 0.40, just say we got consensus on that, a majority, then would we have the opportunity, if we decided to go to another tenth of a mil in August, or would we not? You don't believe so, Barbara? We need to find that out, because that's...
I don't think we can. When I talk to.
Well, we need to get some clarity on that, because we've been arguing this point for a whole year, and we should know the answer, and it should be definitive by this point.
Because he'll send out his proposed trim notices to go out to the public, and the public will see that proposed trim notice, and then I've never seen anyone go up on a trim notice, ever.
Yeah, once the trim notice is sent out, you're right.
I would like to quote from the trim notice that's in your packet that says, if the tentatively adopted millage rate is greater than the proposed rate used for the trim notice, each taxpayer in the jurisdiction must receive notification of the increase by first-class mail at the taxing authority's expense. So we could go up. It would be very costly to send a letter to all of the people.
So we can do that, but we don't want to, because obviously we don't want to pay the Postal Service a bunch of money for no good reason. Okay, I got you.
That's what I believe.
All
Yes,
right.
sir.
Good. That's why you're our attorney. You're supposed to help us with this. Thank you.
So, Rob, what do you want to?
Well, I'm just going to say, just for giggles, you know, we did, and one thing I'm proud of, first of all, it's not an entitlement that any of the clinics or hospitals have. It is the taxpayers' money. We're elected by taxpayers, not hospital CEOs or boards, and we're not an insurance company, although there are some similarities. But with that said, you know, we did zero that one year, and then we had $5 million left over, so we were able to give some money out. And then the year I wasn't here, I think we did 0.5, and then last year 0.15. And so if it's going to be costly to go up, I don't want to set it so low where we'd have to do that if we felt at the end of the day that it was necessary. So you know, it was 0.15 last year. And there are needs, but like Sue said, there's on both sides of the equation, the people in the community and also the taxpayers. And at $100 per person in North Lake, which is essentially what this costs, I would just throw it out there, and somebody can go up or down, whatever. I'm willing to listen to everybody's point of view. Propose a 0.40, with the, like I say, being a very unlikely scenario that we would go up from that, but we could go down or we could stay right there. So I'm throwing that out just for argument if I can get a second.
Do we have anyone else that wants to make a comment first?
Yes, I would. Why? The legislation is clear that it's no more than 1 mil. We all know that, in the sense of rehashing that, and it certainly could go down to 0. That's what's in the parameters of this board's decision, according to the statutes. Why sit here and have a self-imposed limitations on the ability of this board to do what the legislation has asked us to do?
The legislation has asked us to set between 0 and 1 mil. We have the discretion to do that. We're not dictated to by the governor or by the legislators of the state of Florida what to do. We have that discretion. That's your choice, Mark, as it is mine and everybody else in this board.
Right, so we could not do that now. We could set it at 1, then we decide what it is. If it is 0.4 later, then we can easily do that, and it won't be expensive to do.
Okay, I'd like to make a comment. I'm opposed to 1 mil, flat out opposed to it. I look at it from 2 different points of view. I have a son that's in the medical profession, and I hear stories all day long of need and abuse of medical attention. I have friends with the economy right now that is in extreme dire straits, can't pay their bills. And I can't do 1 mil to start out with. The most I could do is 0.6, and I won't go any higher. I won't vote any higher on that.
Yeah, and Madam Chair, not that imply that I believe 1 is a millage, because we, again, need to hear the need first, and then you base them out on that. So my point of saying 1 is it's legislatively there, this special meeting, to establish something that only restricts something. We clearly need to find out what the need is, what that certification number, we do not have that. With the prices, obviously, it's going to be some type of a rollback, because we need those numbers. Is that correct? We don't have the value of the homes yet. Is that correct?
That's correct.
Right, so I somewhat rhetorical, the question there. So that based on the need, which we get from information from the providers and the public, then we look at that certification number in July, and then we decide what that millage is to meet that dollar amount that we decide to provide for the purpose of this legislation. So my point of saying 1 is, let's not restrict us. So if we can look at that new number and we look at what the needs are for these providers, we can make that decision. But I wouldn't want to self-limit us to make those decisions. If we split it at 0.4 and then we need to be 0.45, we can't.
Ralph, could you state your motion again for me?
Yeah, I'd make a motion that we set the so-called tentative, or whatever the other term was, millage at 0.40 for this year. And once again, we do have the option if we want to spend more taxpayer money to going higher, but I would hope we wouldn't need to. That is an increase of almost 3 times what it was last year, which I think is significant. The clinics, obviously, and I think the hospitals agreed last year, get their money is what they need, that they can justify, and the hospitals get what's left over. So that'd be kind of a cash cow. It'd probably be the best, because, valuations last year went up quite a bit. If we did 1 mil, that'd been $20 million taken out of North Lake residents, about $100 per human being that lives in this county, in the north part of Lake County. And I think requiring by law people to pay $100 a person, through indirect or direct taxation is unjustified. I think one of the reasons we have some of these problems with indigent in our community is because we tax them too much. That's part of it, and I understand $100 a year
I need a second before we go into this.
Oh, okay, I'm sorry.
Anybody
want to second my 4? Yeah.
you want on a second? I'll do it, second.
Okay.
Open for discussion.
All right.
Now you can open discussion.
I'd like to say something if I can. I have a question for our hospitals that are here tonight. I came on this board last year, and I thought maybe I could do some good for our community. And immediately I started hearing that these hospitals are big cash cows that pay their CEOs exorbitant salaries.
Yeah.
And raising millions, maybe even billions and trillions and quadrillions of dollars to build new buildings and all of that. I just want to know, do you guys really need the money that we're talking about here?
So Andrew Wampler, Vice President of Finance for Central Florida, UF Health. Definitely we do. Our margins are actually negative since COVID. We've been actually losing money in Central Florida because of a lot of things that go along that we don't have control over. So our staffing levels, we continue to have to staff hospitals. I know Waterman has the same issues that we do, and our costs keep going up to continue to staff our hospitals. Through COVID, we had a lot of our regular nurses that live here in Lake County go other places so they could make more money as travel nurses. So when that happened, we had to bring in travel nurses. So it cost us a lot of money to just keep our doors open. As part of that, we've gone through and had to raise, our payments to attract nurses back to our own facilities. With our payer mix being 80% Medicare, add in Medicaid, add in self-pay, we're about 85% that are governmental payers. We don't negotiate that payment. We get told what Medicare is going to pay us. We can't go to Blue Cross and say, hey, look, our costs have gone up 15% for labor. Our supply costs have gone up, another 10%. Blue Cross we can negotiate with, but we can't do that with the federal government and with other payers. So yes, we do need these funds because it goes to, yes, continuing to buy equipment, replace chillers, replace things that get broken. I have a stack of things on my desk right now that we're holding because we don't have enough funds to continue to invest in new things. These are just things that are breaking right now in our facilities. So for the residents of Lake County, not just these indigent patients, but all of the residents of Lake County, we need to continue to do these things because we need to continue to be able to provide the services for all of the residents of Lake County and our surrounding areas. So yes, we do.
Thank you. The mandate put on this district by the state legislature is that we would reimburse the hospitals and clinics for indigent care. We talk about how poor everybody is and how bad the economy is. We're only taxing homeowners. And if you can afford a home, you can probably afford $7, $8 a month. We're not breaking people. We're not asking for enough money to break anybody. And to me, I've been in a lot of situations where things are discussed and debated back and forth. It makes absolutely no sense at all to set a tentative millage rate less than 1. Doesn't mean we're going to do 1. Doesn't mean we're going to pass that. But it means we have the capability to ask for what we need once we find out what our providers need. We can always come down. But if you go at 4 or 1 or 2.2 or 0.4, you can't go up. That's established. We fought this back and forth last year, and now here we are starting to beat the same old dead horse. You can't go up. You can only come down. It makes no sense at all to set it at a low number and then get your numbers and find out what your need is and say, oops, we can't help you. Set it at 1. Doesn't mean you have to do 1, but set it tentatively there and come down to what you need. To me, that's common sense, and maybe that's a little too difficult for some folks.
Mr. Truman, I'd like to ask if the hospitals are in such need, why is UF Health building freestanding ER clinics and other hospitals doing the same thing if they have all the money they need?
I can't answer that.
Well, I can probably give you.
They can answer.
Well, I think they could probably answer it, but to me, when you are trying to meet the needs of your community, regardless of payers or non-payers, you're trying to provide that service to that community. So they are just building they see the need, they're financially able to. Maybe it's due to we are in place in supporting the indigent so that they can be financially in a position to help other people in that particular community. It's just they're building on top of the building blocks and the foundation that they did 10 years ago when they put this together. So it's no different than me putting new tires in my car. I needed them on my car. So that community needed, they wouldn't build it because that community didn't. They're meeting needs for people in that community.
And I can go back on that again when the gentleman stood up and said that he has a pile of papers on his desk for new machines, new this, new that, but they're building new facilities. So replace the machinery that you need in your already existing facility instead of building more facilities. It doesn't make any sense at all.
Well,
You
I
need
think.
it in your main hospital.
I'm not going to fight, I'm not debating where their monies are being spent, but I can tell you, if you undercut if they had $1 million they're supposed to get and they cut $700,000 out of it, there's a lot of things going to get cut, either services for your people in Eustis or services at the main hospital. So where do you cut your services? And they're having to make decisions based on a very large scope. So do you cut the services from the people that need it in Eustis, that they're going to build a little hub, or do you cut the hospital? You got to make those choices at some corporate level.
The bottom line.
And we're not the one making those decisions. We're making choices on funding, not on decisions where they're spending their money. Now, if you want to go serve on their board, go serve on their board.
I wouldn't want to.
You probably don't, but I'm just saying, we're not the ones making decisions where they're spending their money. We're here to help the indigent people and support the community as a whole, all 8 of these ministries, to support that group, however they're doing it.
If I may add a point, and I'm glad we're having this discussion because it's making the point that this money is not being justified to be taken from taxpayers strictly for indigent care. It's being taken to subsidize other things. I invite you to go on Northlake Hospital profiles. A few years ago, I don't know, Mark, shake your head. Have you watched it on YouTube? It's easy to watch. The people there were very honest. I will give them that. Mr. Henderson, I guess, was the former CEO of Leesburg Regional at the time. The reality was this is a shell game. It frankly is. The hospitals by law are required, because they're 2 nonprofits, take care of indigent needs. End of story. That's the end of it, right? That solves the problem. Now you say, well, can they continue to operate? That's their business model. They're in the hospital business. We're not. We're in providing money for indigent care and supplementing that to the extent that we feel is necessary. And we have to weigh into that the people that actually produce the wealth. Guess who that is? The taxpayers.
The voters.
And it's not just homeowners either, guys. It's every piece of property. I own commercial and personal property, and you pay hospital tax on all of it. So when I say $100 a person, I don't mean just homeowners. I mean average. Do the math. 200,000 people, $20 million. That's $100 a person. So that's the point. I want the real numbers, and then we can make decisions. And, 40% is what I threw out. I said I'm willing to talk about that, right? I mean, 0.4. Barbara said 0.6, and she seconded my 0.40. Anybody want to make an alternative suggestion? And we can move on and get started.
We need to do public comment first.
Okay.
Public comment. Anyone for public comment? Mr. Braun?
Be able to clear up a little bit of this question. I guess when you say the hospitals are subsidizing for other things, you mean providing care to the people in the community? Is that what we're subsidizing? Because that's what we're doing, right?
Our job
we're
is
building what we're building.
Indigent care, not everybody in the community, the indigent.
That's right. And by paying for that, you're right. I've said a lot of these things, but there's some new people here who haven't heard it yet. But so indulge me. But the reality is, when you say we're subsidizing the money you're giving us for the indigent care, for the services we provided that otherwise would not get paid, so it would come out of our pockets and we would have less money. When you say that, what we're doing is we're subsidizing so that the whole county has better care. That's what you're right. We're subsidizing, Ralph, to provide care to everybody, to your children, to your grandchildren, to your wife, to your mother, to your significant other. That's what we're doing. And I do never have understood, as a born and raised here, and we've started having these arguments, I have never understood why the big picture isn't seen. Why the big picture of having vibrant, healthy hospitals and health care in a community like this isn't something everybody wants. And if it helps by paying the hospitals for providing some indigent care, then that is great, because you know what? That's an economic driver. We hire nurses, we hire employees. The big picture is having hospitals is like having schools. It's like it's mom and apple pie, Ralph. It's mom and apple pie. You got to have it, or else your community doesn't thrive. No one's going to live here if you don't have urgent cares and places to take their sick kids in the middle of the night. No one's going to live here. Would if you want to not live in a community that has good health care, then go live up in the panhandle in the woods somewhere, and you won't pay taxes for better health care. It's mind-boggling. So yeah, I mean, when I heard that, I just wanted to, I guess, clarify that the money, is it 100% of our budget? No, but it's that difference, right? It's that difference that makes us keep growing and be able to thrive and be able to provide. Like Rick said, we wouldn't build a facility if it was going to sit empty, right? We wouldn't put something out there that isn't going to provide a need out there to the community. So I think maybe that's where I've tried to get us at some point for this district, is to see the bigger picture of saying like, oh yeah, we need to support healthcare in our community. And this is one way we do it. There's lots of ways we do it, right? I mean, there's lots of ways, but this is an important way, right? Okay.
Yeah.
Thank you.
Thank you.
All right, I think it's vote time, since we've had asked anybody else if they wanted to speak.
Yes, there's a point that Mr. Braun made that, again, reading from the legislature, the provision of such indigent care is found and declared to be a public purpose and necessary, as he said, for the preservation of the public health of the residents of the district. What he said, it brings economic growth. Nurses that work in there, doctors, they pay taxes. It's a reasonable thing. Again, I'm very conservative financially, but if you think about these clinics, as Ms. Youngren mentioned, how many volunteers work there? I wonder what other services that are provided for indigent care anywhere, any government entity, of the 85% that they mentioned are funds that come from taxation, are as efficient as these funds. I don't think that anybody's going to get close to that, nor is as much oversight. And also, if there's any scrutiny with it, it's audited every year, and we heard good reports on those audits. So I would think that we should rest in the expertise of those people.
Thank you, Mr. Jordan.
Got one more.
Oh, I'm sorry. Yeah, come on.
I don't really have a dog in this hunt, but I've been a healthcare auditor for 40 years, and I believe that I understand the economics of how it all works, and I might be able to point something out that I don't think anybody has heretofore brought up, and that's that the cost of caring for people is real cost. I mean, there's a cost to caring for the indigent, and it's going to get paid for. Leesburg said they had a loss last year. I audit 6 hospitals in Florida. Not one of them made money last year. 2 of them are real close to bankruptcy. Since COVID, things have not been good for any healthcare providers. But that being said, the cost is going to get paid for. So what that means is that Leesburg and Advent Health are going to go to United and Cigna and Blue Cross and Humana, and they're going to say, look, we need to increase our contracts. You're going to have to pay us more. And they're going to say, okay. They're going to go then to your local plumber and your local CPA firm and to your local law firm and to every employer in town and say, we're going to raise your premiums. And the employers are going to say to all their employees, we're going to pass more of the cost of paying for your health care to you. And because we got to pay the 30% that Humana and Cigna have to keep to take out of it. So the $100 per household turns into $130 per household
per individual.
From people that are working and paying those premiums to their, for their employers to pay to Cigna. And so it really draws money out of the community because those insurance companies are spending the money in Chicago and New York and other places. It doesn't even stay in in your local economy, spinning 6 times before it leaves, right? Which the dollars that you guys put
Right here.
stays here and changes hands 6 times before it ever leaves Lake County, North Lake. And there's some real value to that, just as it's from somebody that understands the healthcare of the economy of healthcare. I just want to point that out, that that's important, as well as the ability of the hospitals to draw down on the LIP program. And the new guys, do you guys know what the LIP program is?
You can go ahead and reveal that, because I don't know if Mark knows that.
Okay. Mr. Braun, you want to explain how that works? And because that's a drawdown of a federal match.
In the legislation, it allows for this, and we might have heard, if you've been on the board, us come up and ask that we be allowed to leverage that money against federal dollars. So for years, it's not quite as lucrative as it was, because the LIP changes every year. Sometimes it's good, sometimes it's bad, but
It's going to be good this next year.
It's going to go up, I think, yeah. And so for every dollar you give, we're able, and I don't know the exact percentage, but we're able to draw down federal dollars that match. Then
you get 45 cents for every dollar.
Yeah.
So
Yeah.
you get 45% more. If you send $1 to Tallahassee, it comes back $1.45.
Right.
That's a pretty good.
Yeah, and so it's a good return. Now, there is caps depending on what your ratios and things, they calculate it each year, so that's how we find out. But we've almost always used the majority of the funds provided here to leverage those funds. And like you said, it comes back into the local economy. I really like the way you phrase it, because it's very true, and that's somewhat what I try to say when I'm talking about the big picture. But we did an economic study, and I think I've shared it in the past. It's been a while, we haven't done a new one, but it's millions and millions of dollars in economic benefit to the community for having a hospital. And you've got 2 really good ones here, and there's a lot of communities that are the size of Lake County population-wise and economic-wise that do not have the health care that you have, and people don't have to drive to Orlando or take an ambulance ride to Orlando to get care. I mean, you know, you talk about like strokes. I mean, you know, these facilities are able to handle a lot of the strokes and not have to be sent to somewhere else, and that time is brain. And I mean, the things that you have here, I can't even, it's part of the reason people do raise families here, right? Otherwise, I don't know that they would. But hey, and it kept me here too, and I'm a local boy who stayed and was able to give back to the community, and that, you know, just even the people we employ, besides the money they spend back in the community, the amount of time and things we give back to the community too. I mean, it's just a big cyclical thing that's very important to your health, your economic development.
So to conclude, I don't have a dog in the hunt, but I do. I don't live in the district. My family doesn't receive care here, but I do want you to understand that, and he used the word leverage. That is the right word. Is, you know, for every dollar that comes through this district and ends up in the provider's hands, you're getting leverage of somewhere between 30 and 45% of additional money coming in from outside of the county.
Does that apply to the clinics as well as the hospitals, or just the hospitals?
The hospitals get the LIP program, and so does Livestream. Livestream gets LIP. They get a lot of LIP. Do you know your? You guys get some also, because LIP stands for low income pool, and so if you have a high percentage of Medicaid that are considered low income, then higher than, I forget what. Do you want to help me explain how all that works? But yeah, come on up. Mark's expert at this stuff.
Okay. LIP funding really began when there was Medicaid expansion. Florida did not partake in Medicaid expansion, but I think, I believe it was Governor Scott maybe at the time or before, they worked out a deal with the federal government. So it is kind of based on your Medicaid population somewhat. I know our Medicaid population's 56%. So we have IGT money, local governmental money.
Intergovernmental
Yes, yes, that we send up to Tallahassee, and then the federal match comes, and that's where you get the additional 45% is the federal match on that. So it kind of skirts around the Medicaid expansion a little bit. It's not, doesn't replace what expansion would do, but it certainly is, because I get the lip reports. I see what all the hospitals get. I see what the federally qualified health centers get, what all the different entities get. It's a lot of money that gets brought back from the federal government just because of the match from the local governments. And North Lake County from community health centers gets a real added benefit because all of my match comes from Orange County, and I spend it in North Lake County.
That's good.
So, there you go.
Let me ask you, though, while we're at it, because I'm learning, I'm listening, I hope you are listening too. As I talked to Phil last time, the South Lake Hospital, as you know, they had a funding mechanism a few years ago, and Governor Scott, when he was in there, because of the way the legislation was, he just, nixed it, just cut it out, right? And, Phil admitted that indigent care hasn't diminished down there. So my point is, if that's happening, why are there not being more special districts like this created in this state, or at least talked about being done or attempted to be done? Because you're getting 45 cents on the dollar return. It'd be crazy not to if this model works, and it actually is a net benefit to the taxpayers.
We have federally qualified health centers all through the state that put this in our FQHC pool of LIP. They all have to get some sort of intergovernmental transfer to be able to leverage those dollars. So this is not the only place. Orange County is not the only place. It happens throughout the state. So it may not be a hospital district board, but it could be a county's general funds.
Mm-hmm.
But somehow, somewhere, money is being allocated, sent up to the state so that more money can come from the federal government.
So that's my understanding. In some counties, there is an allocation towards indigent needs. We're just doing it in a different format.
Different way, yes, yeah. Like I have a number of centers in Orange County. They don't have a hospital taxing district, but they have general revenues that they set for indigent care. So that's how I get.
It becomes a line item at the county level.
So, Lake County, as a county, does not do that. But because we're, graced with, this board in the taxing district, it helps bring down those dollars from the federal government. So I hope that helped.
Okay.
Since you quoted me, I guess, in some ways. Yeah.
I remember everything.
So like in Orlando, the Orange County gives tons of money to Orlando Health.
Yeah.
And they use that IGT dollar match, and you can look it up and you can see what they send up to the state. Orlando sends up a lot more than we do. So every county does do it different. As far as South Lake, that's and so that's really what I wanted to bring. So that's like comparing apples to oranges, right? So South Lake's tax district owned the part of the hospital, right? And they had the ability to use the money for anything. They didn't have to use it for indigent care. They could build buildings with it, whatever they wanted to do. And that board wasn't elected. It was appointed completely. Right. This board's elected. Right. I have said this before, and for the new people here, this is a better way. This is a better mousetrap. And you're right. You know what? More people should do it this way because there's accountability. There's elected officials over it. And you can't spend it just on whatever you want. You actually have to provide care to get it. Now, there is some other places that use PCAN or P-cards and reimburse the hospitals that way, more like an insurance company. I think that's down in the West Volusia, and that's how they do it. Everybody who has health care does it in some way because the HICRA bill does say this is the county's responsibility. So if you're not here, then, and we have talked about this, you have all talked about coming up with another solution, another way to do it. And that would probably fall on this board to be the ones that say, hey, this is a better way to do it. But I would challenge you that this is a very good way to do it, and you have accountability, you have ability to raise, lower the millage. You lose all that control if you do it the other way. Some of the other places do it, and it gets hidden in the counties, a lot of the bigger counties, and it just kind of gets hidden in the budget. I mean, this is out in the open, and there's public debate, and you know, if the room was full of taxpayers who were chanting no, 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 then I understand. If I was in your shoes, I'd be worried about that too. But I can tell you that's why Southlake is a very different model, and I would say it's kind of short-sighted. But they sold to finish that story, they sold their shares of the hospital, and they put it in a foundation, and that foundation gives them money now. So they're still getting some funding.
Okay, thank you.
So if we start with one, which what I want,
We already have a motion.
and we
on the
wind
floor.
up with
We already have a
point
motion,
two,
but we have to take a
what
vote
you
on it
want,
first.
then you'd be happy, wouldn't you?
We already have a motion on the floor that we have to take a vote on first before we start on another motion.
I'm not starting a motion.
I know, I'm just saying, we've already got it. We have to take the vote on that motion because we had a first.
Before we add that, I took the liberty of texting my friend Kerry Baker, who's our property appraiser, and just ask him, and this is obviously unofficial, but say, what do you expect evaluations to go up this year in Lake County? He sent me back 10%. So based on what last year, if you extrapolate 1 mil by my math, which is like I say, it's been a year since I did it, it looks like if you did 1 mil, you'd get probably around $22 million. So if you go with the 0.4 mil, you know, you're looking at $8 million. Now you're looking at maybe 8.6, 8.8, something like that. Based on what Kerry told me, unofficial, unless you want to take my phone text from Kerry as official.
To come off of that, I think 2023, we had an $8 million budget. Was that true? So 2024 is going to be another 20% more, and I don't know what 2025 is going to even look like. So we need to get numbers in front of us so we make a decision.
Yeah, I know. We're just setting a number tonight. So
Yeah, I know.
and I'm not going to go
These
point.
numbers that make.
Yeah, I'm not going to go
Yeah.
1.0. I don't think a whole lot of people on this board are going to do that. I hope not, anyway. And Barbara said she'd go 0.6. I mean, I'd be willing to go 0.45. That'd give about $10 million if Kerry's number's right. And then we work it down from there, or we stay there. So can I amend my motion to be 0.45? Okay. Barbara, you want to second that again or not?
I'll second it again.
Okay, so now we discuss and decide.
And a vote, roll call.
I have a question for clarification, Ms. Kirsty. If it's split or there's no conclusion with this, or if this vote were never to take place, what would be on the trim anyways?
One of them.
Right, so I am not, anyways, thinking in my mind about not addressing, I'm sticking within his motion and your second. But for clarification, if we don't select anything, it defaults to one, correct?
Correct.
Okay, thank you.
Yep.
We have a motion on the floor for 0.45. Going to take a vote. Mr. Harper?
No.
Ms. Hooper?
Yes.
Mr. Hurley? No. Mr. Jordan? No. Ms. Price?
Yes.
Mr. Smith?
Yes.
Someone want to make another motion? I'll make a motion for 1.0.
Do we have to make a motion?
And I got a second.
Do we have to make a motion, though, since it will default to that anyways?
You don't have to.
Just making a statement.
Amanda will be here.
We can be a stalemate.
Roll call.
Do we have a second on that point?
We don't have to do that for,
Okay. We just had a motion on the floor, though, so.
yeah.
You have to have a second. You have to have a second. If there's a motion.
Do we have a second on 1.0? Okay. Okay, we have a second. Roll call. Mr. Harper?
Yes.
Ms. Hooper? No. Mr. Hurley?
Yes.
Mr. Jordan? Yes. Ms. Price?
No.
Mr. Smith?
No.
Make a motion for point 6.
Do we have a second at point 6?
I'll second it.
Mr. Harper?
No.
Ms. Hooper?
Aye, yes.
Ms. Hurley? Mr. Hurley, excuse me.
No.
Mr. Jordan? No. Ms. Price?
Yes.
Mr. Smith?
I'm sorry.
Point 6?
Point 6, oh yes, I'm sorry. Yeah.
Did we have it carry? 3.
3.
Well, we can continue, or we can call it a tie, and it's going to 1 until we get further information. What's the board's pleasure?
Let's go.
I can order pizza.
I was gonna say, I wanna go home.
You could sit here for 4, 5 more hours.
I've got.
I will not go to 1, I will tell you.
I got
I will
double.
not go to 1.
Well, I will tell you, I think it's basically criminal of members of this board to submit 1 mil when even the previous board before the 3 people that got elected who were more in favor of the taxpayers than corporate interest in this county. Let me make one argument. I talked to the sheriff a while back. He's $40 million underfunded. Okay, now I'm not proposing we do away with this 100%, but if we did do away with it legislatively, and I hope there's some stuff possibly being gone, but because of reactions like this is going to force that probably to happen. If this need for this board goes away, there's $22 million sitting out there that could be assessed through the county ad valorem taxes for the actual real duties and function of government, and that's protecting the citizenry through the sheriff's department. We got amazing sheriff, amazing law enforcement, and EMS and groups like that. And there is a ceiling of what you should take from people. It's $100 a person, not $100 a household, by the way, if you do the math. So a family of 4, it's $400. If that money has to be taken, I'd rather be seen going towards the legitimate functions of government, that being law enforcement, being highways, being sidewalks, being schools, being whatever. Subsidizing hospitals for one purpose of indigent care when they're already by law required to take care of that because they're nonprofits, to me is just basically double dipping. It's dishonest and it's immoral. That's my opinion, and I'm sticking to it.
Mr. Smith, I'm going to have to agree with you for a little bit because these hospitals pay very little tax, but they're willing to tax our taxpayers, which I just have a little bit of a problem with. Yes, is it minimal? Yes, that we're paying, but it's the fact that I'm sure, and I'm not making this personal, but I'm sure Mr. Hurley sees this in his church. People are suffering. And people are working hard for every single dollar they're putting in their pocket. I'm seeing it I say this every year. I see it every year, and this year it's even worse. And the hospitals are not paying any taxes. If they are, it's very, very little. But they're willing to take money from hard-working taxpayers in this county. I can't do it. I cannot go to 1 mil.
I may speak. Am I good? Sure. Anyone? Well, first of all, to make the implication that it has something to do with these funds could go somewhere else that's outside of the purview of this board is ridiculous. That would be up to the county commission. And this particular legislation that even puts us here, it's a state legislation. It's established at the state. And that's where this would be remedied if it were not to be continued. But to provide what it has here, as I said when I started, I would commit myself to the oath that I made. And that's whether I would prefer that the amount of what we actually settle on would be 0.1 or something like that, would be great. The lesser tax would be great, but it's what we're supposed to do. What I took an oath to do was to find out what the need was, find out what the collected amount from Mr. Baker is, and then we set a millage based on that amount of money. Do the math. That's what we're supposed to do. So, I mean, we can send the concerns back and forth about what it means to us personally, but it's outside of us. It's a state legislation. So I took an oath to do what it said, and I think to put the cart in front of the horse is to not fulfill the obligation to do what this law says. I'm compelled by the law to do what it says. Now, I do not think higher taxes are necessary all the time. I don't think that's the first way to go solve a problem. But we do have a problem. I recognize there's difficulties with everyone, no matter what their level of income is. It's coming down. We spend less. But as Mr. Braun well said, that's the sentiment I have, having worked in healthcare, having worked at many of these facilities, having a wife that's in it, a daughter that's a nurse, a brother was a paramedic for years. We understand what it's like. And when I took the oath to do that job, I treated those patients, whether I liked them or not. That's a contract I took, whether I felt like they were going to pay or not, whether I felt like they were respectful or not. I did my duty. I kept my opinion to myself. It's outside of that. Not that we couldn't have one, we wouldn't be mistreated and so forth. But the principle behind this is it's outside of. I didn't have the. It's simply this. It's regulated by the law. So, and I don't necessarily think we need 1 mil, but the point of our vote and split was the fact of the question I asked, that why constrain ourselves unless there's something that because it's going to be lower, very likely. I would bet you from anyone else who voted against it, it's likely to be significantly lower than that, because I don't see the need ever been that high. But I don't know what that is until I see that request. So it's foolhardy to usurp the law, so to speak, in my opinion, to say something that doesn't need to be said, unless I'm trying to posture or something or demonstrate something outside of this board. So thank you for listening to me, board.
Mr. Smith, I love you.
I love you too, brother.
And I like you as a man, a friend. But I will not let you send me out of here branded as criminal or immoral, because I'm trying to do what the state legislature mandated us to do. And I would say, in all fairness to you, if you don't want to do what you've been elected to do on this board, I'd suggest you resign and get off of it.
Mr. Hurley, I respect you and I love you. And also, I know a lot about Mark too. And as men of God, Christians, you're stand-up guys. And I think I used the term immoral. Maybe that was a little extreme. But I will say this. I think it's more like you have a lack of understanding. I can assure you, much like a teenage child that you're going to cut their allowance on, they will argue they still need it, whether they do or don't. These people for almost over 50 years before this, Larry Metz got this, where we had the ability to go from 0 to 1, somewhere in between, never said we don't need as much. Why don't y'all just cut it to 0.8, 0.75, or have discretion? They fought it tooth and nail. They do not want to give up the money. They will not give up the money easily. They will argue, justify it, rationalize it, whatever. I've seen it's called a corporation. That's what they do. They're not bad people. That's what businessmen do, right? But the reality is our job is not to support them or listen to their arguments any more than we listen to every other person. They're a part of the system, but they're not the exclusive people we're here to serve. We're here to serve the citizens that elected us first and foremost, which most of the hospitals represent that part of that as well. So my point is it's a philosophical thing. I've had people in their position tell me that they believe it is not the right thing to do. I take them at their word, and I don't believe it is either, because I don't believe the function of government is to support outside interest. And sorry, until the hospital is deemed a government entity, I can't get past that principle. it is nice to give stuff, but when we're complimented because we're benevolent and we're giving, we're not giving a darn thing. We're simply taking money from taxpayers and transferring it to these people. We didn't produce the money. We didn't produce the wealth. It belongs to somebody else, and that's who I'm interested in looking out for.
We're taking the money from the same taxpayers that put us here. They elected us to be here and do this.
Yeah.
Those same taxpayers. If they didn't want us to take their money, they shouldn't have voted for this district to be in existence.
I agree with you to a point, but here's the problem. 3 years ago, or 4 years ago now, they voted for 3 people who openly advertised the fact that they were not in favor of this special district. And so that was in the Daily Commercial, July 30th, 2020. You could read it. And bottom line, that's, that was the information they had to deal with, and they voted for us. Actually, I think I ran unopposed. Some other people did as well, possibly. I don't know that. But the reality is nobody stepped up to run. So I would say the election of 4 years ago carries more weight than the election of 8 or 9 years ago.
Do we have any other motions for tonight? Are we in stale?
Can I make a motion we adjourn?
That's a good one. I'll second that.
You can.
So moved.
All right.
Thank you.
Welcome to the party.
I'll hold your chair for you.
Oh, thank you.
You don't want it rolling out underneath you.